that kind of is a nice segue into our next presenter, Dr. Kevin Maringer from the Pirbright Institute here in the United Kingdom. If I could give the floor over to you, Kevin, to say hello. We're very happy that Kevin can join us. He's also part of our dengue advisory group, and we've had the pleasure of having a session with him before a few months ago in terms of some of the work that we do at the International Society for NTDs. But I'll pass the floor over for dengue diagnostics, challenges and opportunities by Dr. Kevin Maringer. Thank you. Thanks.
Thank you, Kamran, and thank you for the opportunity to speak. And can I just check, can you see my slides all right?
Yep, I think we can see them, yeah.
Yeah, so as Kamran introduced, my research group is based at the Pirbright Institute in the UK, and my research group really is very interested in understanding the molecular basis by which dengue virus is transmitted by the vector, and also how it causes vascular leakage in patients. So really how it causes that really critical part of the pathogenesis in patients. And in terms of studying those aspects, our focus has really been on NS1. So this protein that's secreted into the patient's serum, as Nilika so very nicely introduced earlier. So I'm going to talk about diagnostics today, but our work, I think, could also lead to some very interesting new therapeutic targets. So I'm just going to move on. So Nilika already showed you this slide of clinical dengue and how it presents. I just want to point out a few things that will be important for my talk, which is that the viremia in dengue actually precedes this critical phase where you get severe disease. And as Nilika introduced, there are many factors that contribute to patients potentially progressing onto this critical phase, which are not completely understood yet. But it is interesting that the critical phase comes after the peak of viremia, and I'll come back to that later in relevance to our work. Also, when we think about diagnostics, a lot of diagnostics target the virus or viral products, which of course will detect this viremia, and some target antibodies, which actually come up quite late after infection. So I guess the way I like to think about it is, what's the purpose of diagnostics? And I think there are multiple purposes for diagnostics. The most obvious perhaps is for clinical management. So really confirming that clinical diagnosis that the doctor will have made. And that's really where the diagnostics are at the moment. But I think it goes without saying that the field is very interested in developing new diagnostics that can help predict which patients will develop severe disease, so that we can better manage dengue patients in hospital and really focus on the patients that are at high risk of developing severe disease. There is another aspect to diagnostics, which is that they are important for outbreak monitoring and reporting, so that we can measure both the scale of outbreaks and also which types of dengue serotypes and strains are circulating, and so that we can understand the changing epidemiology of dengue for planning for the future. And so this is just a slide really to highlight the kind of current types of dengue virus diagnostic tests that exist. I'm not going into individual tests, but just the principles behind the various tests that are available. So on the one hand, we have tests where we can isolate infectious virus from patient blood. So if you remember, virus will be present in the blood before the critical phase. Some of the issues with this is that it involves very high training and also facilities for high biocontainment to protect the operators from getting infected with dengue when they handle the samples. And so this is not, always possible in all settings. But also when we think about clinical usefulness, these sorts of virology methods are actually very slow. And so they're not particularly useful for managing patients in the clinic, but they are very useful for outbreak monitoring and seeing which serotypes are circulating. So in the clinic, we have mostly, my understanding is that people are using detection of viral antigens, particularly NS1, to correlate with that viremic phase, and also the detection of viral nucleic acid. And these tests tend to be a lot easier to use, and they're commonly used. Depending on how nucleic acids are being detected, you might need some specialist equipment and training. And And of course, we need to consider costs. So, you know, there are some particularly resource poor settings where actually some of these tests are not routinely used, at least due to resources available. And then finally, another way that one can detect dengue is looking at the serology. So looking at the antibodies that are produced, particularly IgM, which is produced earlier and closer to the point of infection. But if you remember, the antibodies actually come up still relatively late. And actually these sorts of serology are maybe a bit more useful in combination with other tests. And they're very useful for monitoring what serotypes are circulating in a region. So I've sort of listed here what features might be desirable in a predictive dengue diagnostic test. So all of those tests I mentioned to you before, I should have said, are really aimed at identifying which patients have dengue, but they don't actually help us predict which dengue patients will develop dengue hemorrhagic fever, severe dengue, and vascular leakage. So really, we would want to have biomarkers that help us predict progression to severe disease, ideally at the point at which patients already present in hospital, so several days before they will go on to develop severe disease. We would like those tests to have a high sensitivity and specificity so that we can really be accurate in our triaging of patients into high risk and low risk categories. And I think we have to think, of course, very carefully about the sorts of settings that we might be using these tests in, because they won't only be useful in hospitals where we have maybe more resources, but also maybe in more community and healthcare centers or resource poor settings. So ideally, these tests should be low cost, they should be easy to use so that you don't need particularly high levels of specialist equipment or training, and we should have supply chains that are manageable, for example, without cold chain management and that kind of thing. So Nilika also really gave a really nice introduction to the endothelium and how the endothelium is disrupted during a severe dengue. And so I'm going to talk a little bit about our work that we've been doing in this area to understand really how the microvasculature, how the capillaries actually open up to cause that vascular leakage. And so much of the field really has focused on these endothelial cells, which form the physical barrier of the capillaries. But this misses some of the complexity of what the microvasculature actually looks like, because you actually have another cell type also present in capillaries called pericytes or perivascular cells. And these perivascular cells actually, they don't form the barrier itself, but they actually interact with endothelial cells both through direct contact and through soluble mediators, soluble signaling molecules, and they're very critical for maintaining the barrier. So there are some non-communicative diseases where pericyte function is disrupted, and that will also cause vascular leakage, even if there is no direct effect on endothelial cells. So they are really very critical for maintaining the microvascular barrier. And so we set up a really great collaboration with Dr. Paola Campagnolo at the University of Surrey, and most of the work, or all of the work I'll present today, was done by my PhD student, Yin Chung. And so I'm just going to present some of our work of looking at these pericytes and how they're affected during dengue. And I think the first thing to say is, so Nilika showed some really beautiful slides of how you can actually look and see those endothelial cell barriers opening up when you add dengue serum, for example, or otherwise treat them. So we've used a slightly different assay. So here what we're doing is we're growing these endothelial cell monolayers on a membrane, and we can measure what we call the transendothelial electrical resistance. So we can measure the difference in the electrical potential across this membrane. And if the monolayer is very nice and tight, like you would expect for the microvascular barrier, we're going to have a nice high electrical resistance, which we see here in the bold line. If we add NS1 or vasodilatory cytokines like TNF, this will actually cause the barrier to start opening. And what you see is you see a dip in the electrical resistance. So you see as this resistance goes down, this is indicative that these monolayers are actually starting to become more leaky and that molecules are able to go through them. So this is a direct measure of vascular leakage, albeit in this in vitro cell culture system. And so, as Nilika introduced very nicely, many other groups, or several other groups, including Eva Harris's group, have shown that the viral protein NS1 alone will actually cause some form of vascular leakage. This is obviously in a patient in combination with the cytokines that are produced and all the other molecules and NS1 antibodies that also have effects. But we've really started by studying just the effects of NS1. And here I'm showing you a different kind of assay. So we actually decided to look at, so that, you can grow these endothelial cells in monolayers, but what we're doing here is we're growing them in actually a more complex substrate that allows the endothelial cells to form capillary-like structures in 3 dimensions through this substrate. And so this actually looks a little bit more like what a capillary would look like in vivo, as opposed to these monolayers in a dish. And when we have here endothelial cells alone, we see the formation of some capillaries. And when we add parasites, so these really crucial support cells, you can see that there are a greater number of branches, a greater number of these capillary-like structures, and these capillary structures are getting thicker. And that's because the parasites are supporting those endothelial cells in their critical function, and they're helping these capillaries to form. And then we can treat these cultures with NS1. And what you can hopefully see is that actually you start seeing that the branch width, for example, is getting much lower, and these endothelial capillary structures are becoming disrupted as NS1 is disrupting this interaction with parasites. So this was a very interesting finding, showing for the first time that NS1 disrupts this sort of actual interaction between these 2 cell types, which is so crucial for the microvascular barrier. And we can quantify that in various different ways. And here we're looking at the width of the capillaries. And what you can see again here is if you just have endothelial cells, we have a certain width, which we normalize everything to. If you add parasites, you increase that width. So you increase this formation of the capillaries and the barrier. And then you can treat with increasing amounts of NS1. And you can see that the more NS1 you add, the more likely you are to disrupt this interaction. And I think a really important point to make here is that a lot of these studies with NS1 have been done at very high concentrations of NS1 in these cell cultures in other research groups. You do see concentrations of NS1 in this range, but when you look at the spread of NS1 concentrations, even in patients who develop hemorrhage, you can actually have patients with relatively low concentrations of NS1 still develop hemorrhage. And so what's really unique about our system here is that we also see leakage at these lower concentrations of NS1, which are a little bit more reflective of the full range of NS1 concentrations you would see in a patient. And this is going to be the last data slide I show you, but we can then do some other interesting assays. So here we've gone back to our transendothelial electrical resistance assay, where we culture our endothelial cells on the monolayer in this transwell insert. And then we actually have co-cultured these with parasites. And what's important in this assay to understand is, if you remember, parasites can communicate with endothelial cells through direct contacts, as they did in our 3-dimensional culture, but also through signaling molecules that are soluble. And those signaling molecules are much more interesting when you think about developing biomarkers, because you might be able to detect those in the bloodstream. And so here we've set up an assay where you can actually the cells are not in direct contact, but they can signal to each other. And again, you see that the parasites actually increase the strength of this barrier. So here we have endothelial cells alone. You add the parasites and the barrier is strengthened. And if you add NS1 again, or TNF as our vasodilatory cytokine control, you see that NS1 is completely disrupting this ability of parasites to help endothelial cells form this barrier. And I think what this is indicating is that NS1 is actually disrupting soluble communication through soluble mediators between endothelial cells and parasites, potentially very early in infection. And so we're very interested in developing this further to see whether we can use this to develop biomarkers of severe dengue. So I'm just going to finish with this slide. I'm sorry. So we think we've come up with a slightly we think we've come up with a slightly more improved model maybe of NS1 mediated vascular leakage. So in a healthy person, we have our endothelial cells forming the microvascular barrier surrounded by parasites, which are helping support critically that barrier formation. During that dengue virus replication, you're getting the production of these inflammatory cytokines and all these other molecules, including NS1, that will have direct effects on the endothelial cells, as Nilika introduced and many groups have shown. And we think what happens then is that you get some opening of the vasculature, but we think that actually really the big opening, that really like critical vascular leak, actually happens a bit later. And if you remember, the critical phase actually comes after this peak of NS1. So that initially opening of the vasculature would allow NS1 and potentially other cytokines and other factors to then escape from this capillary, start having effects on pericytes, and then start affecting the way that pericytes are able to support endothelial cells. And we think this actually causes a delayed, but then the very big vascular leakage that you see after the peak in dengue replication, through some effect on soluble mediators between pericytes and endothelial cells. And we think that actually trying to understand what molecules are disrupted by NS1 in pericytes are is very interesting for trying to understand and maybe identify biomarkers, but also maybe some new therapeutics that help to prevent this leakage. And so thank you for attention, and I'll be very happy to take questions after the next speaker.
Thank you very, very much for that, Kevin. Some of the very complex interactions in terms of your own work and how that is going to go ahead and ultimately inform a better world for diagnostics, the importance of it, and some of the kind of interplays there between the various phases along in terms of the evolution of dengue post-bite. So thank you very, very much for that. We're having some questions come through from the Q&A. I know you're coughing there. People can't see this because of the virtual backgrounds, but it's a very hot day here in London. So I appreciate the fact that you battled on through that. It's very rare that we have such good weather, and it's excellent day today. So I do sympathize with your dry throat, but thank you very much for battling on.